Mental disorders, created by Delaney, Fugate, and Irene. Mental disorders is a widespread and serious problem. No definition adequately specifies precise boundaries for mental disorders. Currently, the National Institute for Mental Health estimates about 26.2% of Americans 18 and older meet criteria for at least one mental disorder. More than 1 in 4 Americans suffer from a mental disorder. The incidence of mental illness has doubled for children since the 1990s. In 2013, non-institutionalized spending on mental illness amounted to $89 billion, according to data from the Bureau of Economic Analysis Healthcare Satellite Account. A 2008 study found that serious mental illness results in $193 billion loss in earnings each year in the U.S. Bipolar disorder. This is a disorder associated with episodes of mood swings ranging from depressive lows to manic highs. Bipolar disorder is a serious brain illness. It is also called manic depressive illness or manic depression. People with bipolar disorder go through unusual mood changes. Sometimes people feel very happy and are much more energetic and active than usual. This is called a manic episode. Sometimes people feel very sad and have very low feelings and are much less active. This is called depression or a depressive episode. Conventional treatments used in bipolar disorder include mood stabilizers, antipsychotics, antidepressants, antipsychotics, and anti-anxiety medications. Some alternative therapies used in bipolar disorder include magnesium, omega-3s, folic acid, sleep hygiene, and chronotherapeutics such as sleep deprivation, bright light therapy, and sleep phase advanced therapy. The National Comorbidity Study reported a lifetime prevalence of nearly 4% for bipolar disorder. This disorder is found in more than 5.7 million Americans each year. Bipolar disorder is more common in women than men, with a ratio of about 3 to 2. The median age of onset for bipolar disorder is 25 years old, with men having an earlier age of onset than women. Bipolar disorder is not the same as the normal ups and downs people go through in their lives. Mood swings are more extreme than that and are often accompanied by changes in sleep, energy level, and the ability to think clearly. Bipolar symptoms are so strong they can damage relationships and make it harder to sleep, go to school, or keep a job. They can also be dangerous. Some people with bipolar disorder try to hurt themselves or attempt suicide. During an episode, the symptoms last a week or two, or sometimes longer. In an insured population, 7.5% of all claimants with behavioral health care coverage filed the claim, of which 3% had bipolar disorder. Annual insurance payments were greater for medical services for persons with bipolar disorder than for patients with other behavioral health care diagnoses. Bipolar disorder has been deemed the most expensive behavioral health care diagnosis, costing more than twice as much as depression. Total costs largely arise from indirect costs that are attributable to lost productivity. For every dollar allocated to outpatient care for someone with bipolar disorder, $1.80 is spent on inpatient care, suggesting early intervention and improved prevention management could decrease financial impact of this illness. People with bipolar incurred $568 in annual out-of-pocket expenses, more than double the expenses by all claimants. The pathophysiology of bipolar disorder has yet to be determined. There are no objective biological markers that correspond definitively with the particular disease state. However, bipolar disorder does have a significant genetic component. If you are a relative to a person with bipolar disorder, you are 7 times more likely to also develop this disorder compared to the rest of the population. Natural product therapy, folic acid. Folate is a general term for a group of water-soluble B vitamins and is found in leafy green vegetables such as spinach. Folic acid is the oxidized synthetic compound used in food fortification and dietary supplements to treat relative folate deficiency. While similar in structure, the body absorbs folic acid more easily than folate. Low plasma and red blood cell folate have long been associated with clinical depressive disorders. Relative folate deficiency is known to be associated with several neuropsychiatric disorders. Folate is important in preventing the accumulation of homocysteine, which in excess can promote nerve cell damage. Study number 1. Folic acid supplementation for prevention of mood disorders in young people at familial risk, a randomized double-blind placebo-controlled trial. The primary objective of this study was to determine whether folic acid supplementation could prevent first episodes of clinical mood disorders in young people at increased risk of mood disorder by having a parent with either recurrent major depressive or bipolar disorder. 124 participants ages 14 to 24 years at increased familiar risk of mood disorder were randomized to a folic acid group, or identical placebo liquid group, and completed an MFQ, a 32-item scale designed to detect and monitor depression, each month for a maximum of 36 months. The principal finding of this study is that folic acid treatment did not reduce the incidence of mood disorder in a group of participants at increased familiar risk of depression and bipolar illness. The incidence of mood disorders in the folic acid and placebo groups were 14.3% and 17.9%. The group was a self-selecting group, and it was possible that those that consented to take part were more able to cope with life than those who declined. No participant withdrew due to side effects. Monthly reporting of illnesses, medications, and potential side effects elicited no adverse effect of the folic acid or placebo. Long-term folic acid supplementation was well tolerated with no side adverse effects. There was a high level of adherence, but no evidence that folic acid reduced the incidence of mood disorder compared to those taking the placebo. The dose of folate required to produce a maximal lowering of plasma homocysteine is about 1 milligram a day. But to prevent neural tube defect, particularly in those at risk, higher doses of up to 5 milligrams a day are more effective. Doses of folate substantially above what would be regarded as the usual nutrition requirement, about 400 milligrams daily, can produce clinically crucial neuroprotective effects. Folic acid treatment did not reduce the incidence of mood disorders. Study 2. Folic acid efficacy as an alternative drug added to sodium valproate in the treatment of acute phase of mania and bipolar disorder, a double-blind, randomized control trial. The purpose of this study was to evaluate the efficacy of folic acid as an adjuvant therapy with sodium valproate in the manic phase of patients with bipolar disorder, in comparison with a control group treated with sodium valproate and a placebo. Participants included 88 individuals who were admitted to Irene Psychiatry Hospital. The Young Mania Rating Scalings, YMRS, determined severity of mania with grading from 0 to 4. YMRS scores were determined at the beginning and after the first, second, and third weeks of therapy. Randomly separated, one group was given 3 milligrams sodium valproate folic acid and the other given sodium valproate placebo. Data was collected using checklists for each group. This study showed a statistically significant difference between the case and control groups in response to the treatment. Patients experienced greater improvement with the adjunction of folic acid to sodium valproate in the treatment of the mania phase of bipolar disorder. Patients were followed up for only 3 weeks. Writers suggest longer follow-up for evaluating the effect of folic acid on long-term treatment and the recurrence of bipolar disorder. Side effects onset from sodium valproate was an exclusion criteria. However, no side effects were noted in this study. In most studies, the dosage range of folic acid in mood disorders is 2 to 15 milligrams. This study gave 3 milligrams of folic acid to each manic patient in this case group. Suggests further studies to evaluate long-term effects of folic acid in the treatment of bipolar disorders. No side effects were noted in this study. There was a better response to the treatment in patients with bipolar disorder using folic acid as to sodium valproate in the acute phase of mania. Study 3. Comparative evaluation of quetiapine plus lamotrigine combination versus quetiapine monotherapy in bipolar depression, a 2x2 factorial randomized trial. The purpose of this study was to determine if combination therapy leads to greater improvement in depressive symptoms and investigate the effects of folic acid, for which there is some evidence of efficacy in unipolar depression. Patients with DSM for bipolar 1 or 2 who were age 16 years or older and required new treatment for a depressive episode were enrolled from 27 sites in the UK for 52 weeks. Patients were randomly assigned to lamotrigine or placebo and to folic acid or placebo. The severity of depressive symptoms were assessed with a quick inventory of depressive symptomatology, QIDS, which is a 16-item scale covering the DSM-4 criteria for depressive episode, producing a score between 0 and 27. Mean QIDS SR16 scores were no different in those randomly assigned to folic acid than in those randomly assigned to placebo at 12 weeks or at 22 weeks and 52 weeks. Folic acid was no better than placebo in reducing depressive symptoms. There was a statistically significant interaction between lamotrigine and folic acid in 12 weeks, with folic acid seeming to substantially reduce the effectiveness of lamotrigine. There was a high dropout rate in this study noted at 52 weeks. There were 32 serious adverse effects and 17 non-serious adverse events that led to withdrawal of treatment in 17 participants. Symptoms included nausea and stomach cramps, musculoskeletal pain, and edema. Lamotrigine was commenced at 25 milligrams daily and increased gradually to 200 milligrams as in the U.S. FDA prescribing information. Participants not currently taking folic acid with no contradictions to it were separately randomized to folic acid 500 micrograms per day or 0.5 milligrams per day or placebo. Folic acid was no better than placebo in reducing depressive symptoms. Folic acid seems to lessen the effect of anticonvulsant medications, lamotrigine. There were 17 non-serious adverse events that led to the withdrawal of treatment in 17 participants. 5 were judged to be possible adverse reactions to trial medication. There were 32 serious adverse events in 24 randomized participants. These included 1 death by suicide. 2 participants allocated the folic acid, and 4 participants allocated the lamotrigine plus folic acid. 13 admissions to the hospital and 9 participants for other reasons. Natural product therapy, bright light therapy. Bright light therapy is exposure to artificial light which mimics natural light. Bright light therapy is traditionally used to treat sleep disorder as well as various mood disorders. Side effects induced by mood stabilizers and antipsychotics, which are a most important reason for poor treatment compliance in bipolar disorder, cannot be ignored. Therefore, there is a clear need to find an effective adjunctive treatment with less risk of severe side effects. Bright light therapy has been proposed as a promising choice. Light signals are captured by melanopsin containing retinal cells on retina and transduced to electrical signals. The retinohypothalamic tract delivers these signals to suprachiasmatic nuclei, SCN, which can regulate biologic rhythm. The function of SCN is impacted by the dose and duration of light exposure. Melatonin directly regulates SCN through melatonin receptors on SCN, while the functional leaf of SCN is controlled by serotonergic neurons located in the raphe nuclei. The antidepressant effect of light is potentiated by early morning administration in circadian time. Study 1. Light therapy for bipolar disorder, a case series in women. The purpose of this test is to test the efficacy of bright light therapy on participants with bipolar disorder. 9 women with bipolar 1 or 2 were exposed to 50 lux red lights for 2 weeks, then received 7,000 lux light therapy for 2 weeks for 15, 30, and 45 minutes each day. Mood symptoms were evaluated with the SIGH, ADS, and the MRS. Compliance with light therapy was tracked on daily sleep logs. An independent evaluator who was blind to the study completed all follow-up assessments. Morning light was associated with development of mixed states in 3 of the 4 initial subjects, despite continuation of anti-manic drugs. Both women who responded fully to bright morning light without complications had stable bipolar depression and mostly non-seasonal mood episodes. Subject 1, who had past seasonal and non-seasonal bipolar episodes, responded to morning light with rapid onset of mixed symptoms. These findings highlight the potential benefit of bright light therapy for bipolar depression, but need for more research. Of the 5 women who received midday light therapy, 2 achieved full response and 2 showed early improvement but required a dose to sustain response. There is limited evidence still on the differential response to light therapy timing. With a small population studied, only 9 women, it is important that further research be done to test the efficacy of light therapy on men and women. Commonly reported side effects of light therapy included headache, eye strain, agitation, and nausea. 1 woman remained depressed with 45 minutes of midday light, but responded fully to a switch to morning light for 30 minutes a day. Initiating treatment with a brief duration of 15 minutes of midday light for bipolar depression is advisable. The impact of light therapy on the hypothalamic pituitary ovarian axis may lead to disruptions in the menstrual cycle. Women with bipolar illness are highly sensitive to morning bright light treatment. The induction of mixed states is a substantial risk. This study found that optimal response to bright light therapy was at 7,000 lux midday for 45 to 60 minutes. Light therapy is an attractive and possibly effective augmentation strategy to improve the likelihood of full treatment response. Findings suggest a potential benefit of bright light therapy, but efficacy still remains very limited. Study 2. Adjunctive bright light in non-seasonal major depression. Results from clinician-rated depression scales. The purpose of this study was to investigate whether an early antidepressive response can be induced by combining an antidepressant with bright light therapy with the onset of action of antidepressant alone, and whether this response can be sustained throughout the study period. 102 patients received light treatment daily over a period of 5 weeks in their homes, as soon as possible after awakening, but at 10 a.m. at the very latest. Patients received either white bright light at 10,000 lux for 1 hour daily, or red dim light at 50 lux for 30 minutes daily. Patients were instructed to sit a distance of 40 centimeters from the lamp and with their head directed towards the lamp. All patients were treated with sertraline, intended to be administered in a fixed dose of 50 milligrams daily. Depression scores in the bright light group was larger than that of the dim light group. Limitations of this study included some patient dropouts due to side effects to sertraline and light therapy. Treatment-related side effects were nausea, diarrhea, headaches, and eye irritation. Nausea and diarrhea increased equally in both treatment groups, but headache and eye irritation increased most in the bright light group. The dim red light lamp was of the same external appearance as the bright light lamp, but had been changed to red light by use of a red filter and was electronically dampened to emit 50 lux in the distance of 40 centimeters. The bright light emitted 10,000 lux. All patients were treated with sertraline, intended to be administered in a fixed dose of 50 milligrams daily. Increments or dose reductions were allowed to adjust for side effects or lack of improvement in the most severely depressed patients. Mean sertraline doses were 54 milligrams daily in the bright light group and 50.9 milligrams daily in the dim light group. Side effects were generally mild and did not reach a level of interfering with patients' performance. The study results support the use of bright light as an adjunct treatment to antidepressants in non-seasonal depression. Study 3. Clinical efficacy, onset time, and safety of bright light therapy in acute bipolar depression as an adjunctive therapy, a randomized control trial. The purpose of this study was to examine the efficacy, onset time, and clinical safety of bright light therapy in treating patients with acute bipolar depression as an adjunctive therapy. This was the first controlled trial of bright light therapy and dim red light therapy for treatment of bipolar depression in China. 74 patients, ages 18 to 65, volunteered and met criteria for this 2-week trial. The participants were randomized to the intervention bright light therapy and placebo dim bright light therapy groups. Participants' faces were fully exposed without staring into the light every morning for 1 hour between 6:30 a.m. and 9 a.m. during a 2-week treatment phase of this trial. Clinical efficacy of bright light therapy was measured by the HAMD-17 at V2. The participants treated with BLT had a higher response to treatment compared with patients treated with DRLT at the end of this trial. Bright light therapy combined with first-line drug medication showed certain efficacy, faster onset time, and did not increase the rate of switched into hypomania and side effects compared with simple drug treatments for patients with acute bipolar depression. 2 weeks is too short of a time to assess the depression outcomes in bipolar disorder. The study did not measure the seasonality scores and use morningness, eveningness questionnaire to measure biological rhythm, which may affect the efficacy of light therapy. The study did not control the drug distribution and outpatient-inpatient strictly, which may have some effect on the final efficacy of light therapy. No serious adverse events occurred. New adverse events occurred in bright light therapy group, including 1 dizziness, 1 fatigue, and 2 sleep disturbance compared with the dim red light group. Light therapy was administered by light boxes made by School of Physics, Peking University. The bright light therapy device had 180-watt light-emitting diodes, or LED bulbs, of 10,000 Kelvin color temperature. The heights of light boxes were adjusted to make sure the center of the box was at eye level. 5,000 LX at 100 centimeters setting in the BLT device and less than 100 LX in the DRLT device were used. Most adverse events were mild to moderate and responded to treatment adjustments where indicated. Bright light therapy can be considered as an effective and safe adjunctive treatment choice for acute bipolar depression, according to this study. Recommendations: folic acid. Folic acid intake should not exceed the DRI of 400 micrograms daily. Recommended supplementation is administered to 0.5 to 15 milligram doses in various studies. The most pertinent side effect of folic acid is its reduced effect on certain anticonvulsant medications. Bright light therapy. Bright light therapy is most effective when used in addition to other treatments for bipolar disorder. Side effects can range from mild to severe, but are most often mild to moderate. The most common include headache, nausea, and vomiting. Initiating treatment at 15 minutes is advisable. Bright light therapy at 7,000 to 10,000 lux was most commonly used in these studies.
Hi everyone, I'm Irene and the second topic is schizophrenia. Schizophrenia is a chronic mental disorder in which people interpret reality abnormally. It affects how people think, behave, and feel, thereby influencing normal behaviors and could potentially impair daily functioning. There are several terms used to describe the symptoms of schizophrenia. The first one is psychosis, which is a symptom of losing touch with reality. This causes patients to see or hear things that aren't real, which are called hallucinations. Another symptom is paranoia, the intense and irrational feeling of fear and suspicion. And then delusion is a symptom of holding onto untrue or strange beliefs, even when provided with evidence that it is false. Other signs of schizophrenia are having disorganized thoughts, which is inferred from disorganized speech, abnormal behaviors ranging from childlike behaviors in adults to unpredictable agitation, and reduced expression of emotions and withdrawal from everyday activities. This means neglecting personal hygiene or appearance and withdrawing from social activities. Schizophrenia requires lifelong treatment even when symptoms have subsided. Antipsychotic medications are the most commonly prescribed drugs. There are 2 generations of antipsychotic drugs. First generation antipsychotics have frequent and potentially negative neurological side effects, whereas the second generation antipsychotics are generally preferred because they pose a lower risk of serious side effects than the first generation antipsychotics. Some other conventional drugs used to treat schizophrenic symptoms would be antidepressants and anti-anxiety drugs. In addition to drugs, schizophrenic patients also need psychosocial interventions. This type of therapy helps patients learn coping mechanisms, develop or rediscover social skills, and find support systems, just to name a few. Due to the potential side effects of conventional drugs, some patients turn to less invasive alternative treatments. Some of them include aromatherapy, homeopathy, traditional Chinese medicine like acupuncture and massages, herbal medicines like St. John's worts that help with depressive symptoms, and yoga and meditation. Schizophrenia affects more than 23 million people worldwide, but it is not as common as many other mental disorders. It is more common among males than females. People with schizophrenia are 2 to 3 times more likely to die early than the general population due to physical and mental comorbidities. The prevalence of schizophrenia and related psychotic disorders in the U.S. range from 0.25% to 0.64%. The international prevalence of schizophrenia among non-institutionalized persons range from 0.33% to 0.75%. The incidence of schizophrenia is 0.20 per 1,000 people per year. Schizophrenia is typically diagnosed between late teens to early 30s. There is a gender disparity. Males are often diagnosed earlier than women. Schizophrenia impacts not only the patient, but also the families, caregivers, and the wider society. The World Health Organization estimated that direct costs of schizophrenia in Western countries range from 1.6 to 2.6% of total healthcare expenditures, which in turn accounts for between 7 to 12% of the gross national product. In the U.S., the economic burden of schizophrenia is found to be more than $60 billion per year. The direct cost of schizophrenia is money spent on physical and mental health treatments, drugs, appointments with specialists, emergency room visits, etc. Indirect costs would be loss of productivity, criminal justice involvement, social service needs, unemployment, and more. For social costs, the estimated average potential life loss for individuals with schizophrenia in the U.S. is 28.5 years. An estimated 4.9% of people with schizophrenia die by suicide, a rate far greater than the general population. The etiology of schizophrenia still remains poorly understood, but can be described as a heterogeneous disorder generated by a combination of biochemical, genetic, structural, nutritional, and environmental factors like infections and toxins. There are currently theories and hypotheses about the pathophysiology of schizophrenia, and they usually center on either an excess or deficiency of neurotransmitters like dopamine, serotonin, and glutamate. The most popular theory revolves dopamine level imbalances in certain areas of the brain. An excess amount of dopamine in the mesolimbic pathway may be the cause of positive symptoms, such as movement disorders in schizophrenia. Low dopamine levels in the mesocortical pathway may be related to the negative symptoms like cognitive impairment in schizophrenia. Regardless of which neurotransmitters are off-balanced, schizophrenia is associated with an imbalance in inflammatory cytokines. This leads to immune alterations that affect the communication between the brain and the immune system. The first natural product that has been found to help prevent and manage schizophrenia is fish oil. The biochemical compound in fish oil is the polyunsaturated fatty acid omega-3. Omega-3 fish oil contains both DHA and EPA. It is naturally found in fish like salmon, mackerel, herring, and tuna. Omega-3 fish oil supplements are most commonly consumed by cardiovascular patients due to its function in lowering blood pressure and reducing triglyceride levels. Studies have shown omega-3 has a relationship with schizophrenia. People with mental or psychotic disorders generally have lower omega-3 blood levels, which suggests omega-3 has a role in mental disorders. Omega-3 has anti-inflammatory properties that may help dampen inflammation in the brain, as well as protecting neurons from damage. As we talked about earlier, inflammation and cytokines have a role in the pathophysiology of schizophrenia, so omega-3 may potentially address those issues. Omega-3 is also linked to reducing many schizophrenic symptoms such as depression and anxiety. This first study wanted to determine whether omega-3 polyunsaturated fatty acids reduce the rate of progression to first episode psychotic disorder in adolescents and young adults aged 13 to 25 years old. The design of the study was a randomized, double-blind, placebo-controlled trial that ran from 2004 to 2007. 81 individuals at ultra-high risk of psychotic disorder participated in the study. The intervention group took 1.2 grams of concentrated marine fish oil every day for 12 weeks, whereas the control group took coconut oil pills every day. During the study, participants were not permitted to take antipsychotic medication or mood stabilizers. Results showed that 4.9% of participants in the omega-3 intervention group transitioned to psychosis, versus the 27.5% of participants in the placebo group. The difference in risk progression to psychosis between treatment groups was 22.6% and a 95% confidence interval. Omega-3 also significantly reduced the positive, negative, and general symptoms of schizophrenia and improved level of functioning when compared to the placebo group. Some limitations of the study were that the participants were all young, it did not have a big sample size, and omega-3 did not help with depressive symptoms. As for the safety and side effects of omega-3, this study did not find any clinically relevant side effects, but it did note that too much fish oil may cause GI symptoms like nausea and loose stools. The second study was done in 2014, and the objective was to determine whether a combination of omega-3 and alpha-lipoic acid, or ALA, is effective in preventing schizophrenic relapse after antipsychotic medications were discontinued. This study chose to incorporate ALA because it was an antioxidant that was hypothesized to reduce neuronal injury. The study wanted to see if omega-3 combined with a metabolic antioxidant is more effective than placebo in preventing relapse. The study was a randomized, double-blind, placebo-controlled study in South Africa. 33 individuals who have had their first episode of schizophrenia and were discontinuing their antipsychotic treatments were enrolled in the study. The intervention group took omega-3 and ALA pills, while the control group took olive oil pills. Anti-anxiety, hypnotic, and antidepressant medications were permitted throughout the study. Patients were followed up to 2 years or until they relapsed back to schizophrenia. Of the 21 participants in the intervention group, 19 relapsed within 2 years. Of the 12 participants in the control group, 9 relapsed within 2 years, indicating the percentage of relapse was lower in the placebo group. However, one participant in the intervention group completed 2 years without experiencing a relapse. The study concluded that there was no evidence that omega-3 and ALA supplementation prevented schizophrenic relapses. Limitations to the study were it had a small sample size, the age of the participants were considerably older than the typically young patients of schizophrenia, and the addition of ALA may have masked the benefits of omega-3 supplementation. The safety concern with the study was the high relapse rate for all the patients, and as for side effects, no interactions between ALA and fish oils have been reported. This third study was done in 2016, and it assesses the efficacy of omega-3 fish oil without the addition of an antioxidant like in the previous study. The objective was to see if omega-3 fatty acids reduces the symptoms of schizophrenia. The study was a randomized, double-blind, placebo-controlled parallel group trial set in Poland. 71 participants aged 16 to 35 with a diagnosis of first episode schizophrenia participated in the study. The intervention group took 2.2 grams of fish oil every day for 26 weeks, while the control group took olive oil pills. Results showed a 50% improvement in symptom severity was achieved more frequently in the intervention group than in the placebo group. Omega-3 intervention was also associated with an improvement in general psychopathology, depressive symptoms, level of functioning, and clinical global impression. The limitations to the study was a lack of an objective measure of omega-3 intake, since it was not possible to assess its concentration in the red blood cells of the study participants. 26 weeks may also not be long enough to see all of the results. And lastly, the sample size was still relatively small. One observable side effect of the omega-3 supplementation that was noted in this study was an improvement in constipation in the intervention group. 2 out of the 3 studies showed benefits of taking omega-3 for schizophrenia. It reduced schizophrenic symptoms and improved level of functioning. All studies focused on relatively new schizophrenic patients. Omega-3 supplementation was found to be unsuccessful in preventing a relapse episode. Side effects of omega-3 seen in the studies were nausea and loose stools, but other side effects of omega-3 include fishy breath or upset stomach. The doses of omega-3 in all 3 trials were under 3 grams per day because overconsumption may increase the risk of bleeding. In conclusion, more studies about omega-3 supplementation are needed to consider longer periods of supplementation and for different levels of schizophrenia. The second natural product is folate or folic acid. Both are forms of vitamin B9. They are often used interchangeably, but there are differences. Folate is the natural form, and folic acid is the synthetic form. Folate is naturally found in leafy greens like spinach, and folic acid is usually in fortified foods like cold cereals and flour. Folate is involved in cell growth and DNA formation and expression. Some common applications of folic acid supplementation are preventing miscarriages and neural tube defects and preventing folate deficiency, which is commonly seen in alcoholism, kidney dialysis, and ulcerative colitis. The relationship between folate and schizophrenia as folate deficiency is commonly seen in schizophrenic patients. This suggests that folate supplementation will have some influence on schizophrenia. It is also linked to one of the theories about the pathophysiology of schizophrenia through altered single carbon metabolism. Because it will come up later in the studies, I want to briefly explain the relationship between folate and homocysteine. The folate cycle and homocysteine metabolism pathways are connected, and they have an inverse relationship. Often when folate levels are low, homocysteine levels are high, and vice versa. Some of the studies will also pair folate supplementation with vitamin B12, and that is because vitamin B12 helps facilitate the action of folate in the folate cycle. The studies will also mention positive and negative symptoms of schizophrenia, and that does not refer to the good and bad symptoms. Positive symptoms means it is a symptom that is in addition to what someone without psychosis would experience. For example, an addition in thinking would be getting hallucinations, delusions, and disorganized behavior. Negative symptoms refer to the removal of functions that would have otherwise been normal. That could be emotions leading to apathy, social withdrawal, and lack of motivation. This first study with folate was done in 2011 in Massachusetts. The objective was to examine the effect of folate supplementation on negative symptoms of schizophrenia. The study was a randomized, double-blind, parallel group trial with 28 stable adult schizophrenic outpatients. The intervention group had 2 milligrams of folate every day for 12 weeks, while the control group had a placebo. Results showed folate supplementation did not significantly affect the negative symptoms compared to placebo across the entire cohort. The study also looked into the genetic aspect and found that subjects with at least one copy of the lower functioning MTHFR allele had more negative symptom improvement in treatment group versus the placebo group. This study unfortunately had a lot of limitations. First of all, the study had a very small sample size, leading to low power. Secondly, the study screened out subjects high in homocysteine, and these were the patients that could have benefited the most from this intervention. The study was also unsure if a higher dose of folate would have produced a greater therapeutic effect, since they observed no effects in this study. No safety or side effects of folate supplementation were reported. The second study considers what the first study did not: patients with high homocysteine levels. Elevated homocysteine levels are a risk factor for schizophrenia, and folic acid, vitamin B, and pyridoxine have homocysteine-lowering properties, so this study wanted to look at the supplementation of these 3 in schizophrenic patients. This was a randomized, double-blind, placebo-controlled crossover design study with the crossover occurring at 3 months. 42 participants that had schizophrenia and elevated homocysteine levels participated. The intervention was taking 2 milligrams of folic acid, 400 micrograms of vitamin B12, and 25 milligrams of pyridoxine every day for 3 months. Then the intervention group was switched to the placebo group for 3 months and vice versa. The results showed a significant decrease in homocysteine levels with the supplement intervention. In fact, the low homocysteine levels carried over after the intervention group switched to a placebo treatment. Clinical symptoms of schizophrenia, as measured by the Positive and Negative Syndrome Scale, declined significantly with active treatment versus placebo. One of the limitations to the study was the gender disparity. Out of 42 subjects, 40 were male and 2 were female, so these results could not be for all genders. Also, the subjects had high homocysteine levels, so schizophrenics with normal homocysteine levels may not see the same results. And lastly, this study did not determine the cause of high homocysteine levels, some of which include folate or vitamin B deficiency and certain health conditions like kidney disease or diabetes. No safety concerns or side effects were reported in this study. The third study, done in 2013, had a larger sample size of 140 stable schizophrenic outpatients in the United States. The objective was to determine whether folic acid plus vitamin B12 supplementation reduces positive and negative symptoms of schizophrenia. This was a randomized, double-blind, parallel group placebo-controlled clinical trial. The intervention group took 2 milligrams of folic acid and 400 micrograms of vitamin B12 every day for 16 weeks, while the control group took a placebo pill. Every 2 weeks, participants went to the outpatient clinic to have their medical and psychiatric status assessed and have their blood drawn for serum vitamin B12, plasma homocysteine, and red blood cell folate concentrations. Results showed folate plus vitamin B12 improved negative symptoms significantly more than the placebo, but only when genotype was taken into account. This was only observed in patients with homozygous 4A4T alleles. No relationship between red blood cell folate level and changes in symptoms were observed. Folate and vitamin B12 supplementation did not confer a benefit for positive symptoms or depression scores, regardless of genotype. One limitation to the study was how it based a lot of things off of previous studies that had predominantly European subjects. The current study had a diverse group of subjects, so certain standards and cutoff levels may be suited for European subjects but not for this group in this study. The study briefly mentioned looking at treatment-emergent adverse side effects, but there were no specifics on what these side effects were. These studies seem to show folate supplements only alleviated negative symptoms of schizophrenia and only benefited those with genetic abnormalities in folate metabolism. Therefore, schizophrenic patients with normal folate metabolism may not benefit from folate supplementation. Folate is usually paired with vitamin B12 because it facilitates folate metabolism. Also, high folate levels can mask B12 deficiency, so vitamin B12 is given at the same time just in case there was a deficiency. High doses of folate have been shown to cause abdominal cramps, diarrhea, skin rashes, confusion, etc. None of the studies noted any of these adverse effects, but chronic intake of a lot of folate may also increase the risk of heart attacks and cancer. All of the studies had doses of 2 milligrams of folate a day, which is much higher than the recommendation. More studies have to be done, possibly with folate-only supplementation and also at a lower dose to minimize side effects. A longer trial period and with different genetic variations in the subjects may also provide useful information about folate supplementation and schizophrenia. The two natural products, fish oil and folate, have their own perks for schizophrenia treatment. Fish oil reduces positive, negative, and overall symptoms of schizophrenia, while folate only reduces negative symptoms and only for people with a specific genotype. While studies with folate uses chronically stable schizophrenic patients, fish oil studies only looked at relatively new schizophrenia patients who have only had one first episode schizophrenia. The dose for fish oil should be no more than 3 grams per day, and folate can be 2 milligrams per day if it's an acute treatment. Chronic high doses of folate can cause nausea, abdominal cramps, and diarrhea. These symptoms are similar to the ones for fish oil, nausea, upset stomach, and loose stools. Even though fish oil and folate supplements are easy to find and cheaper than conventional drugs, it is easy to overdose and cause side effects. Also, the benefits may not be the same for everyone because of different levels of schizophrenia and genotypes. It is highly advised to consult with a professional healthcare provider before trying any of these treatments. To wrap things up, here are some other therapies for both bipolar disorder and schizophrenia. One of these therapies for bipolar disorder is sleep hygiene. A normal sleep schedule with a set bedtime every day is very important for the mental health of people with bipolar disorder to keep it under control. In pre-bipolar individuals, it seems there is already a problem with their circadian sleep-wake cycles. Omega-3s may be helpful for bipolar depression, not mania. A meta-analysis provides strong evidence that bipolar depressive symptoms may be improved by adjunctive use of omega-3. And lastly, a healthy level of magnesium in the blood seems to be beneficial to people with mood disorders. A healthy level of magnesium correlates with better clinical state for people taking all types of psychotropic medications, including anti-manic drugs and people taking mood stabilizers. For schizophrenia, the naturally occurring hormone that regulates sleep and wake cycles, melatonin, is decreased. It can likely treat medication side effects when used as an adjunct therapy to antipsychotics. Electroconvulsive therapy, or ECT, has been shown to treat schizophrenia accompanied by extreme depression, mania, and other affective components. A small electrical current is passed through the brain, activating it and producing a seizure. The patient is completely anesthetized, so they do not feel anything. The transcranial magnetic stimulation, or TMS, offers a less drastic alternative to ECT. Researchers propose it can treat schizophrenia and reduce hallucinations. Magnetic pulses are directed to the left temporal parietal cortex, but the effects do not last. Before trying any of these other therapies, it is important to do some more research and talk to a professional healthcare provider and specialist. Thank you for listening to our presentation. If you have any questions or comments, please feel free to ask and we will get to them in a timely manner.